So just to continue, drug therapy is really based on preventive therapy first, as well as rescue drugs. And so I'll mention a little bit more about that, but it's very important for preventive therapy for patients to really understand the difference between the types of inhalers that they're on and which one is supposed to be used every day regardless of symptoms for a preventive type drug versus one that has emergent bronchodilator assistance to kind of stop the attack once it's started. So not every inhaler is the same. Some are meant to be preventive and some are meant to be rescue. So you're going to hear about long and short-acting beta-2 agonist, cholinergic, and methylanthines are a few types of bronchodilators that are out there. Mostly we're going to deal with ones that kind of differentiate between short and long-acting. The long-acting ones are preventive. The short-acting bronchodilators are your rescue inhalers. So when you look at through these in terms of drugs, names that are down through here, I won't read those to you, but pay close attention so that you know the difference. So if you have a rescue situation, you're picking a short-acting, beta agonist bronchodilator med, because that's going to be your most common one to administer. And particularly in an emergency, it's critical. So again, we talked about anti-inflammatory because, as we know, some asthma conditions have an inflammatory component to it. For that, they will give corticosteroids, and that could be in an inhaler format. That could be IV corticosteroids or oral. And a lot of times patients will come in and get some IV corticosteroids as well as an inhaler for that. And then they will taper them down off the IV med to typically prednisone in a tapering fashion. So they'll go from 40 milligrams a day for so many days, and then 20 milligrams a day for so many days, and then 10 milligrams a day for so many days until they stop. And what's important to note is when you're on corticosteroids and you're dealing with inflammation, if a person in this kind of situation took a big dose of steroids and then got no follow-up coverage from that, it's going to bring the inflammation down, hopefully pretty well, but they get a rebound effect because they need to get slower, lower increments so that you're kind of keeping the inflammation down from having a rebound effect. So important to know when you're sending somebody home on prednisone to explain how to take that properly. NSAIDs are also, an anti-inflammatory, and then a couple of these other drugs you will see given as well. These are some of your short-acting drugs. You'll also hear the trade name, the generic name used of albuterol, which is a big component of what's given in these short-acting inhalers for bronchodilation. And this just kind of gives you a few side effects and things to know about. It can make people very edgy, anxious to a patient that's already anxious. And you may see heart palpitations. So just be aware when somebody's getting like an albuterol nebulizer and they're getting one right after the other because they're having asthma, it's going to be very common for you to see their heart rate elevate as a reaction to this medication. And it may be more associated with the medicine than them becoming unstable from the breathing status. So it's always important to kind of watch that if respiratory or you are giving them some inhalers or nebulizer treatments with that particular drug, because you're going to see some of that. These are some of your long-acting ones. These are usually given daily. A lot of patients take these first thing in the morning. It's important to note that with inhalers like this, you want to make sure that you're teaching patients the proper technique for using inhalers. So if you're not familiar with that, make sure you review that in the textbook as well. Here is your gamut of things you might see in terms of things that are given. Another key point to note is in some hospitals that we go to, you're going to look, these meds are going to be listed in the MAR, and some places nurses give them, some places respiratory gives them. Sometimes, a lot of places, if it's in a nebulizer treatment that they hook up to the wall, that's something respiratory gives, more so than nursing. But you always need to validate in your MAR if it has a notation in it, is it being administered by nursing or respiratory. I know at Wake Forest that is always the case. It shows up on both of our screens, and so you have to make sure which one you're supposed to give and which one they're supposed to give, which can be kind of aggravating, but just a point to watch for. Other treatments for asthma, you want to have the patients get exercise and activity to promote ventilation and perfusion, but if they have reactions to cold air, or any exercise intolerance that makes them have asthma attacks, then you want basic exercise, but maybe not as strenuous of activity that might set that off. And some kids can play sports and do plenty of things. They just keep their inhalers, handy if they need a little rescue inhaler during doing some of that. Oxygen therapy via mask or nasal cannula is common practice to always put on an acute asthma patient, because they have the opportunity to fairly quickly, if it progresses, become hypoxic, and you want to make sure that you really are prepared with having oxygen in place. Status asthmaticus is the worst, severe, life-threatening episode of asthma. It intensifies once it begins, and it often does not respond to common therapy. So typical things when a patient's in status asthmaticus is to get hypoxic very bad. You may give nebs after nebs after nebs, other drugs to kind of decrease the inflammation, but once it gets that severe, it usually doesn't respond to much of anything. And this is why asthma attacks need to be really treated as though it is a respiratory emergency, because it's never quite clear, when you look at somebody, oh, yours is going to be, status asthmaticus and yours is not. There's not a way to predict that very well. The patients can develop a pneumothorax and can go into cardiac respiratory arrest. Treatment for this is IV fluids, potent dilators that they give systemically, steroids and epinephrine, which is an IV drug that they will give, and of course oxygen. And many times this is going to lead to an intubation, and of course a lot of these drugs are given in the intensive care unit after you get them moved from the ER to that setting. So you won't see as much of that, but the thing is, you can be on a nursing unit somewhere and somebody walk in with the wrong kind of perfume or something unexpected, and suddenly somebody go, into an asthma attack on the floor. So it's not always that it's this person coming in from home from the ED. An asthma attack can happen anywhere. So you just need to be prepared for all that you can be, because if a patient has a history of that, it's really sometimes unclear, what everybody's triggers might be that could be different. And so it's best to really be prepared for a serious situation versus not be, and it be detrimental to the patient's life. All right, that's it for asthma, and I'm going to cut this off here, and then I'll start a new video that goes over the COPD components.